is Eric Curtis. I will be doing my portion of the respiratory cardiovascular exam for nursing 383. I'll begin by washing my hands, introducing myself to the patient, and providing a brief explanation of the exam. So we'll begin by doing a general overall assessment. Betty is breathing nice and easy, not in any acute distress. Chest rise and fall is symmetrical side to side. We'll begin our respiratory assessment on the posterior side. Again, we would have the gown open in the back to be able to do a complete skin assessment as well at the same time, which has already been done. So we will start by doing some palpation, and we will start on one side and palpate above the scapula, and then move to the other side, and we are checking for symmetry, any tenderness from one side to the other, and then we move down on the inner side of the scapula, and we'll palpate systematically down the back. It's going side to side, and noting any tenderness that is elicited anywhere on the back. Following the palpation, we will do the same manner, percussion, again start above the scapula, and listening for a sound, trying to target in between the intercostal spaces, and again we would go down side to side and cover the bases that way. Typically the sound you were listening for normally would be resonant sound. Hyperresonance would indicate some obstruction from COPD, and a dull sound would indicate fluid accumulation or perhaps atelectasis. Following percussion, we would do auscultation, again in the same manner, starting above the scapula. Listen with the diaphragm pressed firmly against the skin for one full breath cycle at a minimum before moving. And then again that would be systematically done down the back. For sake of time, we will just kind of speed along. And the sounds that we are typically listening for in the upper areas would be broncho-vesicular sounds and progressing down to vesicular. Should there be any adventitious sounds such as crackles or rhonchi, one could have the patient cough 1 or 2 times and then re-auscultate and see if they had cleared then. That concludes the posterior portion of the exam. Moving anteriorly, again we will expose the patient's front to assess the anterior side. Again, doing another inspection of the skin, noting the color, any presence of lesions, chest expansion being symmetrical, and such. Moving on to palpation, same type of system. Start above the clavicle, palpate on both sides, checking again for symmetry and any tenderness. And then just kind of working across the front and side to side, and then following down. And then on women, it's important to lift the breast and palpate underneath to get to the base of the lung fields. Following palpation, we would continue on with percussion, again that same side to side fashion. For sake of time, we would come down and percuss into intercostal spaces down to the base of the lungs, again listening for that resonant sound. Following the percussion, we would then again listen with our stethoscope and the diaphragm, starting above the clavicle for one full breath cycle, side to side. And again, for sake of time, we would listen down the front. It's important to note that the right middle lobe can only be auscultated from the front side or the anterior side. Therefore, it is important to move that breast tissue out of the way to get a good auscultation on that side. Following assessment of the respiratory, we'll move on to the cardiovascular. We've already done a skin assessment on the anterior portion, so we will be doing an inspection, noticing any pulsations or heaves at either the apex or the base of the heart, as well as, again, the carotids, which we have done in the neck assessment. Palpation. Again, the carotids have already been palpated. It is important to note, only palpate the carotids on one side at a time, noticing for the presence of a thrill, and then the rate and quality and rhythm that is noted. Palpation of the heart. Take the open hand and you would palpate across the base and the left sternal border. And then the apex would be palpated as well. And on females, it's important to have to lift that breast and then palpate the apex at that point. Auscultation of heart sounds. We will then auscultate the various heart sounds, starting in the aortic area. Just have the patient breathe nice and easy and normal. That is the area of the aortic valve. And then we would assess and listen to the area over the pulmonic valve. Down just a touch. Of course, I should be using the bell with this. Sorry. We'll flip to the bell and listen to the aortic area. And then the pulmonic area. And then right below that is Erb's point, and that is where S1 and S2 heart sounds are heard relatively equally. And then the tricuspid area. And then the mitral area, or the apex, again would be at that fifth intercostal space, mid-clavicular line. There again would have to lift that left breast to auscultate those. Presence of murmurs. If there is a murmur that is heard, it is heard best with the diaphragm of the stethoscope. And then it's also important to note that cardiovascular assessment is done with the patient in the upright or sitting position, with the patient leaning forward, as well as with the patient lying on their left side. That concludes my portion of the respiratory cardiovascular assessment. I will conclude by washing my hands and thanking again my patient, my mother-in-law Betty, and my wife, the videographer, Tammy. Thank you.